Hi everyone, my name is Katelyn and I'm a third year pharmacy student at UConn. I'm going to talk to you today about some novel FDA drug approvals that happened within the last couple years, specifically 4 different medications. The first one's Qvivic, the second one is Sebinko, and then we'll talk about Astarus, followed by Libalvi. So the first one I want to go into is Qvivic. Its generic name is daridorexant. It is manufactured by Idorsia and it's FDA approved in January of this year. It is currently pending controlled substance scheduling. The expected availability is in May of this year. It's indicated for insomnia, sleep onset, or sleep maintenance, and that is backed by clinically significant results from 2 randomized controlled trials. The class is hypnotic dual orexin receptor antagonist, also known as DORA. Other orexin receptor antagonists currently on the market include Belsomra and Dayvigo. Its mechanism of action is that it blocks orexin A and B from binding to their subsequent receptors, which then suppresses the wake drive. Daridorexant is available as an oral tablet. It's got an onset of about 30 to 40 minutes, but that can be delayed if a patient takes it with or immediately after food. It is a substrate of CYP450-3A4, and that's hepatic metabolism. The primary route of excretion is via feces and then urine, but primarily as metabolites. So daridorexant does require some dose adjustments. If it's being co-administered with moderate CYP3A4 inhibitors, it does require the lower dose of 25 milligrams nightly. There is no dosage adjustment required in kidney dysfunction. However, there is with liver dysfunction. There is no adjustment necessary for mild impairment, which is the Child-Pugh class A, but in moderate impairment, dosing is a maximum of 25 milligrams a night because the AUC may be increased in moderate impairment. And the medication has not been studied in severe impairment, so they are not currently recommending its use in this patient population. There is no available data currently on use in pregnant women, but in one animal reproduction study, the drug did not cause toxic fetal malformation at doses up to 8 and 10 times the maximum recommended human dose of 50 milligrams, but still they concluded that the risk is currently unknown. And there's also no current data on lactation and its presence in human milk or the effects on the breastfed infant. There are a few contraindications and precautions as well. You want to avoid giving a narcoleptic patient this medication. You want to avoid co-administration with strong CYP3A4 inhibitors because it increases exposure to the drug, which can increase the risk of adverse events. And you want to also avoid co-administration with strong or moderate inducers of CYP3A4 because it decreases drug exposure and may reduce the efficacy of the medication. And use of alcohol or other CNS depressants may lead to further CNS depression and create an additive impairment of psychomotor symptoms. Some clinical pearls to be mindful of is to have the patient take the medication within 30 minutes of bedtime, and they should have 7 or more hours remaining before they have to wake up. Again, the onset may be delayed if taken with or immediately after food. And the risk of daytime impairment is increased if taken with less than a full night of sleep left, or if a higher than recommended dose is taken. So if this happens, you want to caution against driving or other activities that require mental alertness, and their fall risk may also be increased. Some adverse effects may include headache, which is the most common. It was reported in at least 5% of patients, followed by dizziness, drowsiness, fatigue, and nausea. Some rare side effects that were noted were hallucination or sleep paralysis. And a class effect of hypnotics is that they have been associated with worsening of depression. So some things to note are to have patients notify their doctor if they do have behavioral or mood changes, or if any hallucinations occur, or if they're not able to move or speak up for several minutes while going to sleep or waking up. They should definitely also report any muscle weakness or if they are feeling sleepy throughout the day. So the second medication I'll go through is called Sebinko, also known as abrocitinib. Its FDA approval date was January of this year. It will be made available in the coming weeks as per a Pfizer press release on the approval date. It is indicated for refractory moderate to severe atopic dermatitis, and it's a Janus kinase 1 inhibitor, also known as JAK1. Its mechanism is that it reversibly inhibits JAK1 enzyme by blocking adenosine triphosphate binding site and then preventing signaling of IL-4, IL-13, and other cytokines involved in the disease state. It does come in multiple strengths, 50, 100, and 200 milligram oral tablets. It's got an onset time to peak about a little less than an hour. It is metabolized via CYP2C19, 2C9, 3A4, 2B6, and it does have 2 active metabolites. And its half-life elimination is about 3 to 5 hours for those active metabolites. Some dosing considerations are to not initiate this medication if a patient has an active serious infection, a low platelet count, a low absolute lymphocyte count, ANC, or hemoglobin. In kidney impairment, they recommend if eGFR is 30 to 59 mils per minute or moderate impairment to dose 50 milligrams once a day. If eGFR is less than 30 mils per minute, which is noted as severe, or a patient has end-stage renal disease or is on renal replacement therapy, the use is not recommended. In liver impairment, for mild to moderate impairment, there is no dose adjustment necessary. So that's going to be your child PU class A or B. But in severe impairment, use is not recommended because it has not been studied. Some dosing considerations for abrocitinib is that in CYP2C19 poor metabolizers, the drug showed about a 2.3-fold higher increase in AUC. So you want to do the initial dose at 50 mg once daily, and then after you can increase to 100 milligrams as tolerated after 12 weeks. You also want to avoid administering live vaccines immediately prior to, during, and immediately after therapy. And some clinical pearls are that it can be administered with or without food. Do not crush, split, or chew the tablet, and there is a copay savings card available for patients. Some adverse effects that you're going to find with this medication would be upset stomach, vomiting, dizziness, headache, nose irritation. They might have signs of a common cold or flu, might feel tired or weak, might have some acne, mouth or throat pain or irritation, or stomach pain. Some rare effects that have been seen with this medication in trials were heart attack, stroke, blood clot, infection like fever or chills, warm, red, or painful skin sores, lumps or growths on the skin, shingles, changes in eyesight, and it does carry a black box warning for serious infections, mortality, malignancies, major adverse cardiovascular events, and thrombosis. The next medication I'll talk about is called Astarus, also known as serdexmethylphenidate, and dexmethylphenidate is a combination drug. So its approval date was in March of last year. It was on the market as of July in last year, and it's indicated for ADHD in patients ages 6 and up. The class is a central nervous system stimulant, and it is a Schedule II controlled substance. So the mechanism is not really entirely known. So methylphenidate blocks the reuptake of norepinephrine and dopamine into the presynaptic neuron, and then serdexmethylphenidate is a prodrug of methylphenidate. So methylphenidate IR is one of the first-line therapies recommended for children and adolescents with ADHD who have like moderate to severe dysfunction, but that one's usually typically dosed twice a day and can be a burden when you're considering like parents and other caregivers and how they have to go to school and then take it in the afternoon. So methylphenidate IR does have a quick onset of 20 to 60 minutes though. So when you combine it with the serdexmethylphenidate, the medication provides a continuous extended release effect throughout the day and only has to be taken once in the morning. It does come in various strengths, and it is an oral capsule. So the metabolism as a prodrug, serdexmethylphenidate is converted to dexmethylphenidate mainly in the lower GI tract and then into inactive metabolites. It's excreted primarily in urine and then feces. Its half-life elimination 5.7 and 11.7 for dexmethylphenidate. Some dosing considerations. There are no dosage adjustments in manufacturer labeling for liver impairment or kidney impairment, but it does note that it has not been studied. But in kidney impairment, PK has shown that little unchanged drug eliminated in urine. So dosage adjustment in renal impairment is not required. Some contraindications are concomitant use with or within 14 days of MAOIs and heart issues. So anyone with known structural cardiac abnormalities, cardiomyopathies, serious heart rhythm abnormalities, or coronary artery disease. It is recommended to perform a pre-treatment screening to assess for the presence of a cardiac disease before initiating this medication, because sudden death, stroke, and MI have been reported in adults with CNS stimulant treatment at recommended doses. And also sudden death has been reported in pediatric patients with cardiac issues taking central nervous system stimulants at the recommended doses. In pregnancy and lactation, there's not enough data on this particular medication. However, methylphenidate's drug monograph states it is present in breast milk and to monitor infants for adverse reactions such as agitation, anorexia, insomnia, and reduced weight gain. Data regarding use in pregnancy with this medication is limited right now, and outcomes data is conflicting also in just methylphenidate. Some clinical pearls are that you would like to administer this medication in the morning without regard to food. You may open the capsules and sprinkle into 50 mils of water or 2 tablespoons of applesauce and administer it immediately after or within 10 minutes of mixing. And for this one, there is also a copay savings card available on the manufacturer's website. Some adverse effects can include hypertension, tachycardia, and there are several psychiatric events that may occur. It could include exacerbation of pre-existing psychosis, induction of a manic episode in bipolar disorder, or new psychotic or manic symptoms in patients without a prior history of that. Pediatric could have a slowed growth rate. Patients might not be growing or gaining height, weight, or as expected, and may need to have treatment interrupted if that occurs. That's up to the doctor. And peripheral vasculopathy, including Raynaud's, has been observed. It does generally improve after dose reduction or discontinuation in trials that it's shown. And then priapism. There is a black box warning. All CNS stimulants have a high potential for abuse and dependence. So you want to assess the risk of abuse prior to prescribing and monitor for signs while they're on the therapy. The next medication I'd like to talk about is Libalvi. It is olanzapine and samidorphan. So olanzapine is already on the market as also indicated for schizophrenia. So this one's just added with samidorphan. The manufacturer is Alkermes. It was approved in June of last year, and it is on the market as of October last year. It's indicated for schizophrenia and bipolar I disorder in adults. The class is an atypical antipsychotic, and the samidorphan is the opioid antagonist. So the mechanism of action, olanzapine is an antagonist of serotonin, dopamine, histamine, and alpha-1 adrenergic receptors, as well as muscarinic receptors. And it works on GABA, benzodiazepine, and beta-adrenergic receptors. Samidorphan is an antagonist at the mu opioid receptors and a partial agonist at the kappa and delta opioid receptors. So the exact mechanism of olanzapine in schizophrenia and bipolar disorder is not known, but efficacy is thought to be mediated through the combined antagonism of dopamine and serotonin receptor sites. It does come in various strengths, and it is an oral tablet. It is metabolized, olanzapine is metabolized via UGT in several CYP enzymes to an inactive metabolite, while samidorphan is also metabolized through several CYP3A4, 5, 2C19, and 2C8. Excretion is mostly in urine, some in feces. Half-life elimination of olanzapine is a bit longer than the samidorphan. So some things to consider in dosing is that contraindications are in patients who use opioids. You want to delay initiation of this medication for a minimum of 7 days if they're on short-acting opioids, and 14 days if they were on long-acting opioids. In kidney impairment, and those with moderate or mild kidney impairment, there's no dosage adjustment necessary. But in those with severe impairment, with an eGFR 15 to 29 mils per minute, you want to use caution because there's increased exposure to the drug, but they don't have a dosage adjustment necessary. In patients with end-stage renal disease or with an eGFR of less than 15 mils per minute, use is not recommended because it has not been studied. In liver impairment, you want to caution because there's increased exposure in patients with moderate hepatic impairment, but there's no recommendations otherwise. Some clinical pearls are to administer this medication without regard to food, and the samidorphan is used to offset the weight gain in olanzapine. You want to make sure that the patient will store the medication in the original container with the desiccant, and do not divide tablets or combine strengths. And again, there is a copay savings card available on the manufacturer's website. So with this medication, there are several adverse effects and a few black box warnings. So elevated blood glucose levels, prolactin levels, and triglycerides could occur. So weight gain is listed because olanzapine is known to cause weight gain, but the samidorphan is used to offset the weight gain. And in clinical trials, this combination drug has shown to cause significantly less weight gain than other antipsychotics. So in a 24-week phase 3 multicenter double-blind study, it assessed the weight gain at 24 weeks. 30% of olanzapine-only patients exhibited weight gain of 10% or higher, versus about 18% in the Libalvi group. The percent change in weight from baseline was about 6.6% in olanzapine versus only 4.2% in Libalvi. So for some patients, not having as much weight gain or maybe not at all would be more beneficial to use this drug in combination. Safety and efficacy of this drug has not been established in pediatric patients, also to note. There's also less common symptoms like dry mouth, drowsiness, dizziness, headache, sedation, constipation, decreased neutrophils, and orthostatic hypotension. There is a rare risk of neuroleptic malignant syndrome with administration of antipsychotic drugs. You want to watch for symptoms like hyperpyrexia, muscle rigidity, delirium, autonomic instability, and this could be potentially fatal. And then DRESS has been reported with exposure to olanzapine. So you want to watch for symptoms with cutaneous reaction like rash or dermatitis, eosinophilia, fever, lymphadenopathy with some systemic complications affecting the liver, kidneys, or heart. That is also sometimes fatal. Tardive dyskinesia, potentially irreversible involuntary movements in the patient, dysphagia or seizures, and it does carry a black box warning. This drug is not approved for treatment in patients with dementia-related psychosis. Clinical trials did not include sufficient numbers of patients 65 plus. So if you guys have any questions, feel free to leave a comment. I will try to answer them in a timely manner.